Good afternoon, everybody. Hello. A very good afternoon, everybody. Welcome all of you to this National Medical College Network relay of academic sessions. At the very outset, I would like to thank Dr. Kumbalkar, Dr. Parate for giving us all the opportunity to conduct this small CME and share with you the ideas and concepts in FNAC of Thyroid and the Bethesda System for reporting Thyroid Cytology using this NMCN platform. Friends, goitrous thyroid gland has plagued us since many centuries. Thyroid disease is most common endocrine disorder and is different from other endocrine diseases because of its visible swelling and ease of diagnosis. An apparent worldwide epidemic of thyroid carcinoma began in 1990s, and by 2010 it became the 5th most common cancer in women. India alone has 42 million people suffering from thyroid diseases. Clinically, apparent nodules affect around 8.5% Indian population, but by ultrasonography, around 60 to 70% population has one or more nodules. 95% of the thyroid diseases are found in women, and almost 90 to 95% are benign, comprising of colloidal adenomatous nodules, follicular adenomas, and chronic lymphocytic thyroiditis. Malignant disease are in the tune of 5 to 10%, even in the iodine sufficient areas. The prevalence in children is much less, but the rate of malignancy is pretty high as compared to the adults, and it is around 25%. Evaluation of a goiter involves detailed history taking, and the first and the foremost that you have to ask the patient is history of neck irradiation. The family history is not only applied to medullary carcinoma, but also to PTC. If in a family 2 to 3 members have microcarcinoma in the thyroid, removed for some other reason, really puts the family at risk, and then the children need to be screened by USG. A systematic physical examination is simple, inexpensive, but an imperfect method, and unfortunately it is neither sensitive nor specific in the diagnosis of cancer. There are a host of tests that are available, and the most important and the simplest one that you should have before you do an FNAC is the TSH, which has a value of 0.3 to 5 international units. Because euthyroid and hypothyroid patients are most safe to diagnose, undergo FNA, but if the patient has a low TSH value or is clinically hyperthyroid, the patient must undergo a radionuclide scan to know whether there is diffuse involvement of the thyroid gland, as in Graves' disease, or there is hyperfunctioning hot nodule, and such nodules are carefully you should do the FNAC, as they are very vascular and they are highly cellular. However, in pediatric patients, hyperfunctioning nodules can be malignant. FNAC has revolutionized the diagnosis of thyroid nodules, and it has become the keystone in the management of thyroid nodules ever since when Martin and Ellis in 1930s pioneered this technique. Now, what are the major impacts seen in the FNAC era? Adding FNAC to the armamentarium of diagnostic tests has reduced the number of thyroid operations by 35 to 75%. It has increased 2 to 3 times the proportion of cancers found at surgery. Prior to the era of FNAC, only 10 to 25% of all the thyroid surgical specimens would show cancers. FNAC has reduced the risk of not operating on patients with cancer, and it has helped in the early detection of microcarcinomas, which have a very good chance of cure. And probably it has helped in interrupting the possible progression of differentiated neoplasms to anaplastic carcinomas. With all its limitation, FNAC has shown a consistent high sensitivity and specificity world over. So by the end of this talk, you will all tell me whether FNAC is a screening or a diagnostic test. Now we do have other diagnostic modalities like the frozen section or the core biopsy with their own limitations. For example, the core biopsy, which is a threat to FNAC for many organs, has taken a back seat and never became popular for thyroid because of the anatomical location of the gland and its vascularity. And also the core biopsy does not go any further in discriminating between follicular adenoma versus carcinoma. FNA has a lower complication rate as compared to core biopsy, but it has the inability to check for cellular adequacy, which is possible with rapid on-site evaluation using FNAC material. But it does have some advantages, like it is preferred in fibrotic tumors and whenever you want to do immunocytochemistry, like in medullary carcinoma. Kuch problem hai? वो विंडो नहीं चाहिए? वो खुशबू करेगी. With the increasing use of FNAC, a need was felt for uniform terminology amongst not only amongst the pathologists for clarity of communication, but also for exchange of information amongst the clinicians and the pathologists and across institutions, and to frame very clear and comprehensible reports. And therefore, TBS RTC was formalized in 2007, and the first edition came up in 2010, second edition came up in 2018. This classification came at a time when there was growing body of literature showing inconsistencies in histopathologic diagnosis of thyroid carcinoma even amongst the experts. Follow-up studies were showing overdiagnosis and overtreatment of PTC, and there was a need for risk stratification. There were more and more clinical and radiological guidelines, and there was pressure of following these guidelines. And there was also growing understanding of pathogenesis and molecular basis of thyroid cancer, and this was at its peak. So the validity of TBS RTC, this reporting system, has been extensively investigated by systematic meta-analysis and large review studies. These analyses have shown a growing trend in the sense that more and more institutions worldwide are adopting this tiered classification. Why? Simply because it puts across the FNA interpretation to the referring physician in terms that are succinct, unambiguous, and clinically useful. So we are all very familiar. There are 6 diagnostic categories in the Bethesda system, and then you have a very nice column where there is the ROM, that is the risk of malignancy, has been calculated meticulously, and then you have, in front of each category you have the usual management recommendations. The category 3 and 4 are the indeterminate categories, and even some people think that the category of suspicious for malignancy should be taken in the indeterminate zone. Now, the category 3, that is ATP of undetermined significance or follicular lesion of undetermined significance, is a very heterogeneous category where you have all types of follicular or non-follicular cells showing you the ATP. But the category 4, that is the follicular neoplasm, suspicious for follicular neoplasm, is a very homogeneous category and contains only follicular patterned lesions without nuclear ATP or nuclear features of PTC. Another thing that we have to note that in this indeterminate, 2 indeterminate categories, we have two names, AUS plus, follicular neoplasm, suspicious of follicular neoplasm. These are synonyms. Just remember that these are synonyms, and a consensus was not made by the experts while framing this system, and so they remain like that. And for the clarity of communication, Bethesda has given you guidelines that how your report should look like. So when you report category 3, that is, you write the description of the category, ATP of undetermined significance, and then in the bracket you write Bethesda 3. but never report it like only numerical, Bethesda 3, or only a benign, the name of the category, whether benign or AUS. So you need to put both the things very clearly on the report, and then you can put any note, after putting this diagnosis, you can put your descriptive diagnosis, which we are generally used to. Now, a paradigm change that has occurred in the last 7 to 8 years is the recognition of a new category, that is the NIFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Now, this has an impact not only the histopathological classification of the thyroid tumors, but it has also impacted the Bethesda system and the risk of malignancy. We'll see that a little later. So, the current era of NIFT with this, the latest 2017 Bethesda classification published in 2018, we thought that there would be some changes in the risk of malignancy, but ultimately there was not much change in the percentages of the ROM, because this observation was based on limited number of retrospective studies, because NIFT was thought to be a very indolent, a benign like neoplasm, so we thought that the risk of malignancy will come down, but it hasn't as much, and more studies are required in future. So, but in this classification system, they do give you the Bethesda system recommends that you add a note in front of the category if you are suspecting nuclear features of NIFTP. We will see what are those nuclear features. So here you have an optional note column in the end where you can clearly write that these are the so-and-so features favoring FVPTC, but cytology cannot differentiate from FVPTC and NIFTP, and this possibility should be considered. So you have this facility and you can write this elaboratively in your report. Notes and recommendations, they can be useful for the surgeon, because especially when they have the facility of doing molecular tests. At present, molecular tests are being done in the Western countries, and cytology is being triaged with these molecular tests. So they are using the Afirma and the Thyroid V3, which is a simple machine, just like we do PCR. You put the FNA material inside the machine, and within 3 hours, you have a whole panel of mutations that you can see. The commonest mutation is the RAS mutation, and then you have other mutations. And so at present we have 45 independent molecular signatures, and they are being checked. The RAS oncogene mutations, either alone or along with other mutations, are present in almost 50% of cancers, and they are proving useful for not only diagnosing but also subtyping the follicular neoplasms and follicular patterned tumor. But they are pretty costly, and it will take some time for them to come in our country and be used, bring them in practical application. So with this brief introduction, now I present to you Dr. Suprita Nayak out there for her talk. She is a very excellent speaker. She has a lot of cytology material, and she will deal with the basics and benign and deal with the descriptive categories 1 and 2. I will try to iron out the creases of the category 3 and 4, the indeterminate zone, and after me, Dr. Anupama Gupta will deal with the categories 5 and 6 with all her dynamism. Thank you so much.